Hydrophilic petrolatum contains what as an emulsifier? What I got was, I think, sodium something, but I couldn't find.
Sodium laurate. What?
Yeah. Yeah, that's what I got, but I couldn't see like for if it's cholesterol or. But did anybody else get anything else, or we can come back to this. So number 207. Suspensions and emulsions are coarse dispersions when particle size is usually which one? Anyone with an answer? D. Okay, someone is saying D, 100 to 50. We are on 207. So is everyone okay with D? Is there like a picture or something that we can refer to for this coarse particles? If it can be shared on the group. Okay. Yeah, if you have a picture, kindly share it on the group. So D, I think D is also correct. Unless anybody else has a different answer.
Can you read the what is it? The measurements, the units.
No, I don't know. Is it like micrometer? Micro, I don't know. I can't see.
So,
But I guess we go for D or
okay, according to the picture that I've sent, it's showing that 10 to 50 micrometers is coarse dispersion and 0.5 to 10 is fine. There's the other two pictures. which says that greater than 500 or 0.5 micrometers is for coarse. Is colloidal and fine the same?
No. Those are different things, I think.
What is the difference between colloidal and fine?
Oh, just a minute. I'm seeing that for colloidal, it's less than 2.5, the size. Okay, I'm not too sure. I think colloidal is even smaller than fine particles, but I'm not too sure. And for this question, we don't know what the units are over here, so we can just, yeah, mark it. Okay, so in the next question, the symbol on the capsule 000 represents the dose of the capsule in a day, 3 capsules per dose, capsule type, and capsule size. I think we know this one is a capsule size. It has the different types of capsule size. I think 000 is the one that is commonly used. Yeah. Then Divya has also sent capsule size chart on the group. So yeah, we have the 000 till 5. Yeah. Yeah. So next question. Which of the following is not used as a diluent in tablet formulations? We can just go back. And also Gaius has sent something on the group for colloidal dispersions. They have a particle range of 0.1 to 1,000 nanometers. Coarse dispersions have a larger diameter of 1 to 200 micrometers. Yeah, I think it's all with the size, the diameter. Okay. Um, yeah, so two 205, I think it is calcium stearate. We've seen the picture was even sent, I think it was today or yesterday, where we discussed the different types. Calcium stearate is, okay, I don't know about calcium stearate, but I know magnesium stearate is usually used as a glidant and a lubricant. So I guess we can go with that. Lactose, dicalcium phosphate, and starch are used as diluents, where, yeah, diluents is the same as fillers, right? Diluents is the same as fillers? Question mark. Okay, yes, thank you guys. Yeah. And the most commonly used we've seen is lactose. So we can, is there anything else you guys want to discuss for that? Okay, we can go to the next question. Okay, picking of tablets may be caused by all of the following except scratched punches, static charges on the powder, unsatisfactory lubricant, or excessive compression pressure. What is picking? We can just discuss that.
I think it's sticking to the punch. When it is punched, then when it goes up, the powder goes with it.
Okay, so that makes sense. It's mostly to do with with the punches, or yeah, gas says part of the tablet remains on the punch during compression. Okay, so B is correct. Anybody, anything else that you guys want to discuss for this? For unsatisfactory lubricant, I guess if it would be, if there is more lubricant, then I think it would stick more, right? Or it's the other way around.
No, you're right. You're right.
Yeah. So if there's more lubricant, then there would be more picking. Okay. Then
How does static charge on the powder cause picking?
okay, I don't know how I can explain this, but like static charge, like you see, if you have like positive and negative charges, so that would cause, like, for example, uh if the die has the punches have like negative charge, and then the powder has positive charge, so it would cause like sticking, like it would get attracted. I don't know how. Does that make sense?
Yeah.
Yeah. Yeah, and B will cause gaping, yes. Excessive, yeah. So number 203, all the following factors affect solubility except nature of the solute, pressure, pH, and temperature.
Pressure?
Yeah, I also think pressure. Nature of the solute, again, that's, I think, either if it's the if it's crystalline or amorphous, pH, and temperature. Also in, yeah. The following statements about gases in liquids are all correct except
I have mm, something to ask. Won't pressure have uh an effect. Like if it was for a gas, then if you increase the pressure, then solubility increases.
I'm not too sure. I'm not too sure about that. Anybody else with an answer for that?
I thought all of them affect.
I know nature of the solid pH and temperature effect, but I'm not sure about pressure.
Yeah, I don't think pressure plays any role in solubility.
Maybe for not solid and liquid, but for gases, I think. Okay.
Gas, you're saying? True for what? True for what Sheena said.
For pressure, yeah, according to Henry's law.
But I guess that's when we're talking about
But you see here, they've not even given a specific.
yeah. I would personally go with pressure because I know the rest like have a major effect. Anybody else with a different answer or okay, then we can just we can go to 202. What do you guys think the answer for that one is? 202. What do you guys think? Okay, if nobody has an answer, then we just move on to the next. Mm. 201. The following, okay, the girl has said critical solution temperature is the temperature at which complete miscibility is raised. So D makes is the answer. Okay, thank you. 201. The following are all methods of increasing solubility except complexation, common in effect. I think that has to be common ion effect, but I'm not sure. Hydrotropism and co-solvency. Liz is asking, what if its nature of solvent and not solute? But it says nature of solute. Or you're asking, Liz, you can unmute and ask, or you, okay, it would still be correct. Like, okay, we can just go on to that other question, Shina. Ways of increasing solubility except, I think we even saw this. What's common in effect, or is it supposed to be common ion effect? Yeah, it's the common ion effect. It describes the effect on equilibrium that occurs when a common ion is added to a solution. Okay, so for this one, for common ion effect, it usually decreases solubility, but the question is asking for increasing solubility. For hydrotropism, I think Divya had sent something. Yeah, hydrotropic agents are stated as ionic organic salts which help to increase or decrease the solubility of a solute in a given solvent via salt in or salt out effects, respectively. Salts with slow salt in of non-electrolytes are called hydrotrophic salts, and the phenomena is called hydrotropism.
Was it the one that we said we are adding a large amount of the stuff?
Yeah,
it is.
yeah, it's
Thanks.
that one. Yeah, so it results in increase in solubility. Even complexation, it increases solubility, and also co-solvency increases solubility. For common ion effect, it usually decreases solubility. So yeah, that's the answer. Okay, next question. The quantity of gas dissolved in a liquid is in general governed by Henry's law. We just discussed that right now. And we've discussed these laws before, so we're good to go. 199. The following solutions are the most widely used in pharmaceutical practice except gas in liquid solutions, yes. Liquid in liquid, yes. Solid in liquid, yes. And liquid in solid, I doubt it. Anybody else with a different answer? D. Okay. Brownian motion describes a random movement of dash in a solution. Molecules, small particles, ions, or cliques. Small particles.
Excuse me.
Yes.
199.
Mm-hmm.
Why not solid in liquid?
Solid and liquid. Don't we have like so many preparations of solid and liquid?
Oh, it is except. Sorry.
Yeah. Suspend. Yes. Okay. Fick's first law of diffusion relates to flux of diffusion coefficient, flux to time, flux to distance, and distance and time. What is Fick's law? So, Fick's law of diffusion states that the rate at which a molecule moves through a material is proportional to the concentration gradient. And it's inversely proportional to the thickness of the membrane. So that is Fick's law. Request to review Brownian motion. Okay, anybody to take us through that kindly? Anybody for Brownian motion?
Brownian motion is the random motion of particles suspended in a medium. This motion pattern typically consists of random fluctuations in a particle's position inside a fluid subdomain, followed by a relocation to another subdomain. Each relocation is followed by more fluctuations with the new closed volume.
Thank you. Guys, anything else? Guys, are you good? Okay, thank you. Okay, so next question. The rate of zero order reaction is independent of reactants. We know this. We don't even have to go through this. The rate of oxidation of a phenolic ring is highest at Phenolic ring, we know it's a benzene ring with an OH. So the rate of oxygen would be highest at what pH? And if you're going for CYC,
Would it be alkalinic? Because since it's a weak base, a weak acid, it would have to lose a hydrogen ion in order to be oxidized. So it will lose it to a base in an alkaline environment. I'm not sure I'm thinking out loud.
that makes sense to me. Anybody else with a different answer or different explanation? Mercy, you can repeat that, please.
Pardon?
Please repeat.
No, I am not sure. Correct me if I'm wrong. So I was saying, phenol, it's a weak acid. So for anything to be oxidized, it has to lose like a hydrogen. Like for it to remain the positive charge. So it will be favorable in an alkaline condition for it to lose it to the base, making it oxidized.
Okay. Yeah, so alkaline pH favors deprotonation to a phenolate ion, and at alkaline pH, phenol will be in an ionized form, which is more reactive, thus easily oxidized than a non-ionized form of OH. So all these indicate that in an alkaline pH, there will be oxidation of the phenolic ring. Okay. According to the Arrhenius equation, describe the effect of dash on the rate of a reaction. We have seen the Arrhenius Yeah, temperature is the answer. The reaction rate equation dash describes, okay, we know that's first order. An oral antidiabetic, drug that acts mainly by decreasing gluconeogenesis and by increasing peripheral utilization of glucose is. Gas is saying metformin. Yes, I also agree. Glibenclamide is a sulfonylurea. What is the mechanism of action? Yes, we can do an overview of diabetes. Guys, you can take us through DM, please, or anybody else that is willing to.
What are some can take us through DM if he's available.
Okay, so we know diabetes is basically when there's an issue with insulin, yeah? So it can either be type 1, type 2. Type 1 is also known as juvenile. It's commonly seen in children and it's a genetic defect and it's insulin dependent. Type 2 is non-insulin dependent. That means that the receptors are insensitive to insulin. So the common signs and symptoms we can have is thirst, frequent urination, weight loss or weight gain, dryness of the mouth. Type 1, the treatment is basically insulin. We've looked at the different types of insulin, but we can just do a quick recap. We have ultra short acting, that's Lispro, Aspart, and glycine. And the onset is 15 to 30 minutes. You give it 15 minutes before meal. Then we have the short acting, which is regular insulin. And it is the only insulin that can be given IV. The rest of them are given subcutaneous. Intermediate, you have the NPH. And for long acting, you have glargine, lantus, and dastrimi. Type 2 treatment, okay, you can give non-pharmacological by asking the patient to do exercise, control their sugar. What else?
Please,
Go for a
you
walk.
said which insulin is given IV?
Regular.
Okay, thank you.
Yeah. Then for type 2, the treatment, you have various drugs, but so the first class is insulin secretagogues. That's you have sulfonylurea and meglitinides. And just by the word secretagogues, it increases the stimulation of, okay, it stimulates the pancreas to increase insulin. Yeah, it stimulates the pancreas cells to increase the secretion of insulin. So in sulfonylurea, you have glipizide, glibenclamide, those GG ones. Main side effect is hypoglycemia and weight gain. Then in the meglitinides, you have rapaglinide and nataglinides. Then you can have second other class is glucagon-like peptide agonists. They also secrete insulin from beta cells. An example is liraglutide, liraglutide and dulaglutide. The side effects are GI effects and pancreatitis. Then you have the DPP4 inhibitors, the gliptins. So the mechanism of action is basically inhibits the DPP4 enzyme. So that means that the endogenous GLP-1 will increase. Basically, that will increase the insulin. So you have sitagliptin, saxagliptin, linagliptins. Then you have the insulin sensitizers. In that you can have biguanides and thiazolidinides. The mechanism of action for biguanides is basically what's written there: decrease gluconeogenesis and increase the insulin sensitivity. It encourages weight loss. The major side effects here are GI disturbances, peripheral neuropathy. It decreases the vitamin B12 absorption, causes lactic acidosis, which increases the risk with renal impairment. Then you have the thiazolidine, those one, that is rosiglitazone and pioglitazone. The mechanism of action is insulin sensitivity. Major side effect here you have is bladder cancer. Then we have alpha glucosidase inhibitors, which decrease the absorption of carbohydrates. Example is acrabose and miglitol. Yeah. The last one is the SGLT2 inhibitors. They inhibit the sodium glucose cotransport 2. So that will reduce the glucose reabsorption and increase the urinary glucose excretion. Major side effect is UTI and DKA. And the example is dapagliflozin and empagliflozin. You can add, I think that's what I have. Any additions?
Okay, thank you, Shina, for that good summary. Just to add on another difference between type 1 and type 2, we can differentiate them using the C-peptide levels. So for type 1, we don't usually have what is it called? First of all, insulin, when it's released, also C-peptide is released. So in type 1, we don't even have insulin release. So the levels will be less than 1 nanogram. But in level 2, it will be greater than 1 nanogram because insulin is being released, but the cells are they're not being sensitive to it. Another thing for the sulfonylureas, like tolbetamide, I think, and glibenclamide, they usually have what is it called? Antidiuretic effect. So they cause like what is it called? This increase in ADH, and so it will cause that. So also for treatment in pregnancy, we usually use insulin is the main therapy that we use in pregnancy, but glibenclamide can be an option in very rare cases.
And also for type 2 DM, the treatment should be based on the HbA1c levels. So if the HbA1c level is 6.5 to 7.5, then monotherapy is preferred. Usually metformin is usually the one that's given first. Then if it's between 7.5 and 9, the HbA1c levels, then dual therapy is is given with metformin. So you give metformin and another oral agent. And if it's more than 9%, then now you have the oral agents, and even insulin is given then at that stage. Yeah. Anybody else that wants to add anything? Okay, I think that was a good overview for DM. We can move on. Number 191. The life-saving drug given parenterally in severe status asthmaticus that will act by inhibiting phospholipase A2. Gas is saying prednisone.
Aminophylline.
Gas, why prednisone then? Why are you saying prednisone?
Of course, steroids inhibit that phospholipase A2. The aminophylines, the theophylline, the methylxanthines, I think they inhibit the phosphodiesterase, leading to buildup of the cyclic AMP, which will cause the bronchodilation. Perhaps Lydia can enlighten us further.
Lydia, you can tell us why aminophylline?
Okay. Pardon the question, please.
You said the answer is B.
Have not texted anything.
Oh, it wasn't you, sorry. There's somebody who said the answer is aminophylline.
Oh, no, I had just chosen her.
Oh,
Her.
okay.
Yeah.
So
Sorry.
repeat the question, please. Repeat the question.
What do you think the answer is over here in 191?
I think the answer is C, because the mechanism of action of corticosteroid by inhibit phospholipase A2.
Okay. So the
Yes.
person who said aminophylline, kindly tell us why you chose aminophylline.
I chose aminophylline not because I saw it in the books. I saw it in the hospital being given. That's why I chose that.
Anybody with a different answer?
I
Why
think,
not
I mean,
epinephrine?
Why not epinephrine? Somebody answer that.
no, I think it's about the mechanism of action. Like, let me see. Okay, not all. Yeah, these drugs, A, B, and C, at least I know A, B, and C, you can say they all have a role to play in asthma. So it's the mechanism that distinguishes them. Epinephrine is a beta 2 agonist. Aminophylline will inhibit PDE. Prednisone would be an general anti-inflammatory. One of its mechanism will be inhibiting phospholipase A2. Hence that choice. Like the mechanism is what has led. Okay, personally, I've chosen that based on that mechanism of action.
Yeah, that also
Okay,
makes sense. Hmm?
kuna press ni one. kuna place nimeona wamesema epinephrine can bind to phospholipase A2 as well. And I'm thinking because they're saying the less of medication, and usually status asthmaticus is usually an emergency case. Will prednisolone really work in such a case? It requires time to function, like for its effects to be noticed.
Prednisolone is a long-acting corticosteroid. At that particular time, it will not help us. But epinephrine is the adrenaline that you're using. Aminophylline at one time ilikuwa imetolewa. So we have been using epinephrine, which is adrenaline in the pharmacy.
Becky, excuse?
Yes? Hello?
Becky, is the
Yeah?
mode of action of, I'm saying, inhibiting phospholipase A2.
It's not a matter of inhibiting phospholipase 2. When we look at adrenergic receptors, on adrenergic receptors, alpha 2 is a bronchodilator and a vasodilator. So in that mechanism, it will open the bronchioles muscles. Look at the adrenal receptors.
I think I'm with the gas on this one based on the MR.
What about the question itself? Or we are now ignoring what the question is trying to ask? That the life-saving drug given. I think there is a statement there that should be put in consideration as much as we are, that will, I think that statement of that will act by inhibiting the phospholipase A should also be put into consideration as we are answering the question.
Okay, maybe that one can work on that issue. I have not checked the mechanism of action of epinephrine if it will work on the phospholipase A, but I know with status asthmaticus, we are using epinephrine.
I have something to say. This question is asking the severe status asthmaticus. It's not an emergency. So I think we should focus more on the mechanism of action by inhibiting the phospholipase A2. This is not an emergency, and it's severe status asthmaticus. So we should focus on the mechanism of action and stop focusing on the other life-saving drug given.
But status asthmaticus is an emergency.
Status asthmaticus actually asthma which keeps on recurring after using maybe the gold standard drugs for asthma, it doesn't get better. It's not an emergency status asthmaticus is not an emergency if I'm not wrong.
Just to disagree with you, Dr. Rikiasi, too, that status asthmaticus is the acute asthma. Like it's the asthmatic attack. It's the way we say status epilepticus. You have epilepsy, yes, but status epilepticus is when now you're having the seizure itself. Same with status asthmaticus. Like you have asthma, but the asthmaticus, this is when you're having this attack, the typical attack.
Okay, let me just read for you something. Status asthmaticus is severe asthma unresponsive to repeated courses of beta agonist therapy such as inhaled albuterol, subcutaneous epinephrine. It is a medical emergency that requires immediate recognition and treatment. So we are both correct.
Ah, great, great. So meanwhile, I think we can do at least an overview of asthma, then we just highlight or we mention the management of acute asthma or the management of asthmatic attack, because as much as steroids do not work immediately, they still have a role. We do give systemic corticosteroids, whether oral or IV, depending on the severity, on that during or rather after the asthmatic attack, there's a place for steroids. Yeah.
Maybe I can give it a try.
Yeah, please.
Thanks, Dr. Gas. So for asthma, it's an inflammatory condition, mainly characterized by coughing, wheezing, and breathlessness. In terms of the pathophysiology, I think we said it's a type 1 hypersensitivity reaction. So when the allergen is exposed to the airways, this like it causes a bronchial hypersensitivity, and activation when during this period the parasympathetic pathway is also activated, and an increase in acetylcholine released from the how do you say it, from the postganglionic fibers will activate the M3 receptors, and then now you have bronchoconstriction. Yeah, just basically. And then now for when we look at treatment, now we'll look at treatment in terms of whether it's acute or whether it's chronic. For chronic, we know we can give inhaled corticosteroids. Yeah, and this inhaled, the examples are like budenoside, fluticasone, and basically how they work, they usually bind to the glucocorticoid receptor, and then they decrease formation of the cytokines, which can cause the expression of the IgE, as we've said before. Also, something special about them is they also reduce an influx of the eosinophils, which also play a crucial role in the hypersensitivity. And then this was and then now we also have the SABAs, so the short acting beta antagonists. Those ones we've talked about them a lot, salbutamol and tebutalin. And then we have the LABAs. So now that's where we have the salmeterol, formoterol, those ones. And basically, as you said, so these ones will bind to the beta receptors of the smooth muscles and therefore cause bronchodilation. In terms of adverse effects, now we are having beta-1 receptor blockers. So beta-2 receptor. They can also work on the beta-1 to cause tachycardia and arrhythmia in the heart, and can also lead to tremors, hypokalemia. So be careful with other drugs. And then something special is normally these LABAs are usually combined with inhaled steroids, because studies have shown dual therapy usually results in less deaths, and yeah, so that's why they usually combine. So most times when you have chronic, you opt to have combined, you opt to combine. And then just other drugs, we have the leukotriene antagonists. This one, These ones mainly reduces the healing pattern and inhibit nicotine receptors in the
Willie,
yeah.
we can't
Am I
really
loud?
hear you.
Or do you want me to be louder? Where do you want me to go?
Yeah, like right now you're okay.
Okay, so where did I leave you off? So that I can keep going. So we've talked about the SABAs and the LABAs, and we said they're blocking the beta 2, but they have a beta 1 effect, and that's why we have tachycardia and arrhythmias. So, and then now we're talking about the leukotriene antagonists. Those are the Lucas. So Zifilucas, Montelukast. Those are examples. We're saying that they're leukotriene antagonists. So they reduce the eosinophilia present in the sputum, and they inhibit leukotriene receptors present in the respiratory bronchi. We also have the long-acting muscarinic antagonists. These ones inhibit the M3 receptors present in the smooth muscle, and therefore leading to bronchodilation. Basically, they're just anti-muscarinic drugs. So, effects of urinary retention, angle closure, constipation, and dry mouth. Yeah. And then just looking at and we can also use the oral corticosteroids. Those ones we have, basically they just reduce lung inflammation. And we have prednisolone. Important to note, now we have a lot of we have a lot of adverse effects caused by corticosteroids, so be careful with the bone density. And that's why you can, when you're giving oral corticosteroids, you can give them with calcium, vitamin D, and bisphosphonates. They also cause GI bleeding, which may be increased by NSAIDs and SSRIs. Yeah, in terms of acute treatment, we give oxygen to treat the hypoxia. So this oxygen, normally we want to maintain it at around 94 to 98%. Yeah, we have the bronchodilators. Now we'll use our short-acting, and we have corticosteroids, which are given orally. So that's oral prednisolone, about 40 to 50 mg. Though, if not possible, you can give intravenous hydrocortisone, which is about 100 mg 4 times a day. In cases where you can't give when the patient is not responding to the beta 2 agonists, you can also give intravenous magnesium. Yeah, and then also sometimes you can give antibiotics if bacteria was the cause. Yeah, and also as Gaia said, the intravenous aminophylline, yeah, which is also a treatment which can be given for acute by inhibiting the phospholipase A1.
Thank you, Willie.
Willie, the antibiotic that's given is azithromycin, right?
Honestly, I think, yeah, just from what I read, I think it depends on your findings, but I'm not very sure on that.
And I think even in refractory or severe cases, you can add monoclonal antibodies such as omalizumab with the other agents. Yeah. Anybody else?
Those ones are usually mainly given during chronic because they usually decrease the IgEs and also decrease inflammation. Yeah, so mainly when you're giving those ones, it's usually due to allergic asthma. And it also, like in the event that you also want to reduce the use of corticosteroids, you can give them, but important to note, just because they're biological therapies, they can lead to an anaphylactic reaction.
Thank you, Willie. Anybody else that wants to add anything for this or the treatment? Pictures have also been sent on the group. So back to this question. What is
I'd
the
like to
answer?
add something.
Uh-huh.
I would like to add, someone said the aminophylline. Aminophylline actually is a salt of theophylline. Actually, theophylline, ethylamine has been added to theophylline to increase water solubility for IV administration. I'm not saying the answer is aminophylline, I'm just trying to add something on the aminophylline.
Thank you. Okay, so back to this question. What is the answer? Or we leave it at that and we move on.
Okay, I have a question. Can prednisolone be given as an IV? Because this is
Yes, I think it
okay.
can be given. Yeah. Okay, so next question. To get synergistic effect, all beta-lactam antibiotics can be combined with. Guys, you're saying C4? 190. Okay, aminoglycosides. And why not the other? Why not the others?
Okay, so for beta-lactam antibiotics, they inhibit cell wall synthesis, right? And aminoglycoside usually inhibit protein synthesis. So how they work synergistically is that now beta-lactam antibiotics will weaken the bacterial cell wall or like kill it. So that will allow the aminoglycosides to enter the cell, like it can easily enter the cell of the bacteria. Hence now aminoglycoside will do the protein synthesis inhibition. So that will be added like two effective additions of how they will inhibit that. So mostly combination for beta-lactam antibiotics and aminoglycosides used in severe cases or resistant cases of infections.
Okay, so then how comes we don't use them? Why wouldn't you get a synergistic effect if it's used with like macrolides, which also inhibit protein synthesis?
I think the aminoglycosides are the most common ones. I think we had mentioned that, Edmonds had mentioned that, so the other options, I'm not really sure.
Okay. Anybody else? We use for serious infections such as infective endocarditis. Okay. So everybody okay with that with this question? Then we move on. Okay. Next, the mechanism of action of clindamycin is similar to that of erythromycin, yes. penicillin and cefuroxime, we know it's cell wall inhibitors. And Cipro is topoisomerase inhibitor, topoisomerase 4 inhibitor, right? Yes. Okay, so next question. 55, kinda. Okay.
Okay, Viral,
Uh-huh.
I searched to take you back to the previous question.
Uh-huh.
So first, why we are not choosing macrolides? Because also macrolides, they do protein synthesis, but the combination of beta-lactam and macrolides are not used for synergistic effect. They're just rather used to increase the spectrum of activity or like for specific infections. For chloramphenicol, the combination of beta-lactams with chloramphenicol is not advised due to adverse side effects, potential side effects. And for quinolones, they already have a different mechanism of action, so they won't go together.
Okay. Okay, thank you. Okay. A 55-year-old male patient with benign prostate hypertrophy may be treated with a 5-alpha reductase inhibitor like C. Yes. Prazosin and terazosin are what's their class?
Alpha blockers.
Yes. And for indoramin, it's also an alpha blocker. And we can do an overview of BPH. Anybody that can take us through that, please? Nightwing, kindly take us through BPH. Okay. Anybody, if you have a picture or a summary, you can share it on the group so we can move on. Most of the systematic antifungals are selectively toxic to fungi because they inhibit ergosterol, because we know that most of them are targeted for that cell membrane because it's made of ergosterol. Yes, transpeptidase is for bacteria. Yeah. The possible interaction outcome between spironolactone and ACE inhibitors include?
Excuse me, question on the previous question.
Uh-huh.
Why the selectivity?
Because fungi are the ones that have the ergosterol in their cell membranes.
And not human beings, right?
I don't think so. We don't have ergosterol.
We have cholesterol.
Yeah.
Yeah, correct.
Okay, so 186. Interaction between spironolactone and ACE inhibitors. Spironolactone are case pairing, so they cause hyperkalemia, and so do ACE inhibitors cause hyperkalemia. So C would be the answer. Lidocaine is an amide, local anesthetic, but also useful as antiarrhythmic. It's classified in which class of antiarrhythmics?
Sodium channel.
Yes, class 1. And also there's a summary for BPH on the group. Should we go through BPH, or that those pictures are okay?
No, we
We
move
go.
on, please.
Oh. Yeah. Okay. We can just go through. Okay, pictures are great. Just for the management for BPH, it's the 5-alpha reductase inhibitors and the alpha-adrenergic antagonists such as tamsulosin that's given. Yeah. Yeah, we can move on then. Sulfasalazine is a disease-modifying anti-rheumatic drug that acts through its active metabolite called 5-amino salicylic acid. Yeah. It's mostly, what is sulfasalazine mostly used for? Over here, yes, it says anti-rheumatic, but what are the other indications for sulfasalazine? Yes,
IBD.
ulcerative colitis.
Ulcerative colitis.
Yeah. Crohn's disease, yeah. Is it used for burns?
The one that is used for burns is called what then?
Sulfadaz.
Yeah, diazine.
Diazine.
That's sulfadiazine, yeah. Not sulfasalazine. Yeah. Okay. Paracetamol is almost free of anti-inflammatory activity. Its analgesic activity is mediated by
Praise dog.
yeah. Yes, is saying D is the best answer. Why is it the best answer, please?
I think it inhibits the action of prostaglandin in the CNS.
I think from what I found, it works like it's an ISO, and so like when you're classifying them, we have COX-1, COX-2, and then we have COX, like the enzymes. We have COX-1, COX-2, and then we have COX-3, which is the isoenzyme of COX-1. So, due to like when they found the analgesic ability that paracetamol has, especially with fevers, they considered that it has an action on the serotogenic descending pathways. So we know serotonin is a CNS, whatever. So just due to that, I think that's how they considered it might actually have direct action on the spinal cord. Because when we are classifying it, we don't put it as COX-1 or the general answer is Evo. The way I found it on some notes, they put it as a COX-3.
Thank you, Willie. Anybody else with a addition? Okay.
I want to add something. The reason you find that almost all the NSAIDs, the reason why they inhibit the COX enzymes, because they have carboxylic acid, which is the key group for binding to the enzyme, but the paracetamol lacks the carboxylic acid, so it's almost free of anti-inflammatory activity. So the analgesic activity is through inhibition. The analgesic activity is what he has explained, but it does not inhibit the COX enzyme.
Thank you, Lydia. And then we can move on to the next question. Research on adrenergic receptors has shown that the endothelium of blood vessels predominantly contains alpha-1, alpha-2, beta-1, beta-2. Yes, on the blood vessels, it's mostly alpha-1. Alpha-2 is commonly found where? In the CNS. Beta-1? Heart. And beta-2 is the bronchioles, right? Okay, guys. So A is the answer over there. (181). Which of the following is not a pregnancy-related physiological change that may alter drug kinetic? Reduced renal function, increased renal blood flow, reduced plasma albumin, and increased hepatic metabolism is not a pregnancy related. Why is there reduced plasma albumin? Okay, next question. Which guys, go on.
What I'm finding on that is that during pregnancy, the plasma volume will increase. Yeah, as Munira is saying,
Okay, makes sense.
is this dilution of albumin. It's not that it has decreased, that
Decrease.
yeah,
It's because of the dilution effect.
exactly.
Okay.
Yeah.
Okay, makes sense. Thank you. Which route of drug administration is most likely to lead to first pass effect? Oral. You never know that. A hydrophilic medicinal agent has the following property: low ability to penetrate through the cell membrane. Okay, that's the one that makes sense because it's hydrophilic. Yeah. If it was hydrophobic, then it would have not been that. Yeah. So hydrophilic agents, they usually require transporters or endocytosis. Yeah. Pick out the appropriate alimentary route of administration where passage of drugs through the liver is minimized. So that basically means avoiding first pass metabolism. Yeah, even I thought of transdermal, but it's saying alimentary route. So then C would be the answer. Or anybody has a different, because that's what I thought. If it's alimentary route, then rectal would. Yeah, so C is the answer. What does the term bioavailability mean? Fraction of unchanged drug reaching the systemic circulation following any route of administration. Okay. What is implied by active transport? Transport against concentration gradient. Yes. Active transport is where you need the transporters. Yeah. Pharmacokinetics is the study of absorption, distribution, metabolism, and excretion. Yes. Two most important sites of drug elimination are kidney and liver. Yes. Drugs least likely to penetrate across. I know, right? Yeah, we wish we get such questions. Drugs least likely to penetrate across membranes are protein-bound drugs, charged drugs, neutral drugs, none of the above. We saw this before, protein-bound drugs, since as long as they're protein-bound, they're not, like, they cannot have any effect, and these proteins cannot cross any membrane. So protein-bound drugs. Does everybody agree with that? Okay. Had there been a choice with A and B, wouldn't that be more correct? Yeah, because it's unionized drugs that cannot cross. I mean that can cross, right? That can diffuse easily, right? Yeah. But I guess in this question, it's charged drugs cannot easily cross cell membranes. It's usually the unionized drugs that cross cell membranes that can easily be absorbed or, yeah. The driving force in drug movement is aqueous diffusion model. Is the drug concentration gradient. Yeah. Which of the following drugs exhibit antimalarial activity by interacting with the hemoglobin in the parasite?
Not quinine.
I know admethrin it inhibits it interacts with the heme in the parasite. Then it has that endoperoxide bridge formation. For quinine, I'm not sure. What's the mechanism of action for quinine? So I'm seeing quinine, it can disrupt the DNA replication of Plasmodium.
It also interferes with the digestion of hemoglobin in the blood stages of the malaria life cycle.
Yeah, I'm also saying that quinine inhibits hematin. No, it inhibits the conversion of hematin to hemozoin, and hematin is the one that's toxic to the parasite. So either quinine or artemisinin. But you see over here, it's saying like specifically to hemoglobin. Does that, when you look at the mechanism of action of quinine, does it still affect I'm not sure. Anybody else? Pablo has written artemisinin reacts with iron in the heme to produce free radicals which damage proteins and other molecules in the parasite. So what would be the answer?
I think hemoglobin is the best one to go. I mean, sorry, artemisinin is the best one to go with.
Yeah.
Considering it actually acts on the hemoglobin, but fast tracks to the hemoglobin, but for quinine, it actually inhibits a product of hemoglobin metabolism. So yeah, so it would actually be the best.
Okay. Is everyone okay for that answer? Okay. So yeah, that one. Vinca alkaloids demonstrate the anti-cancer activity by yeah, blocks mitosis where they inhibit the assembly of spindles, right? It inhibits assembly. Yeah, and taxanes like paclitaxel is the one that they inhibit disassembly. Yes. Okay. Then castanospermine, an alkaloid from that anistrol exhibits anti-HIV activity by inhibiting Okay. Nagal is saying B, glycosidase. Okay. What is it? Okay, yeah, anti-HIV. Okay. Okay, so we
it
move on.
says that
Sorry?
glycosidase is usually important in glycosylation of the proteins, the viral glycoproteins in HIV. So if like there's disruption of now that glycosylation, that will interfere with replication and how the HIV now will affect the human cells.
Okay. Thank you. So we move on to the next question. What crucial feature of penicillin is involved in its mechanism of action? Yes, beta-lactam ring. Should we stop here and we continue from this page tomorrow? Or
yeah, we continue to learn.
But it's anyway almost done. Yeah. Thank you everyone for listening. Thank you.
Yeah, great.